Welcome to another episode from the Veterinary Medicine Digest. Today we will discuss one of the most common, yet frequently confusing, endocrine disorders encountered in canine practice: hypothyroidism. This condition, characterized by a reduction in the production of crucial thyroid hormones like thyroxine and triiodothyronine, wields influence over nearly every organ system in a dog's body, leading to an astonishingly wide spectrum of clinical signs. Our discussion today will explore the multifaceted nature of canine hypothyroidism, delving into its primary causes, the complexity surrounding its diagnosis, the subtle and sometimes dramatic ways it presents in our furry companions, and the therapeutic approaches that bring relief. First, let us lay the groundwork. What exactly causes a dog to become hypothyroid? The vast majority of naturally occurring cases in adult dogs are categorized as primary acquired hypothyroidism, accounting for over 95% of affected animals. The two main culprits here are lymphocytic thyroiditis, an immune-mediated assault, and idiopathic thyroid atrophy. Lymphocytic thyroiditis is essentially an autoimmune inflammatory disorder, where the body's immune system, mistakenly identifying the thyroid gland as foreign, infiltrates the tissue with cells like lymphocytes and macrophages, leading to its gradual destruction. It is widely hypothesized that idiopathic thyroid atrophy, where the functional thyroid tissue is replaced by connective and adipose tissue, might simply represent the final, burnout stage of lymphocytic thyroiditis. Autoimmune thyroiditis is known to have an inherited component, which explains the strong breed associations we often observe. The progression of autoimmune thyroiditis follows a predictable, albeit variable, path. It begins with the appearance of thyroglobulin autoantibodies, often long before clinical signs or overt changes in hormone levels are detected. This phase can last 12 to 18 months. As the destruction continues, thyroxine secretion slowly declines, and the pituitary gland responds by increasing its output of thyroid-stimulating hormone in a desperate, but ultimately futile, attempt to restore thyroxine levels. In the final stage, the thyroid tissue is entirely atrophied, thyroxine levels are profoundly low, and the thyroid-stimulating hormone concentration may either remain elevated or surprisingly return to the normal reference interval. While primary acquired hypothyroidism dominates, there are rarer causes of thyroid dysfunction. These include congenital forms, stemming from defects like iodine deficiency, thyroid dysgenesis, or dyshormonogenesis. Congenital hypothyroidism is especially notable, often leading to mental retardation and disproportionate, stunted growth in puppies. These severely affected young dogs may display signs such as large, broad heads, short, thick limbs, macroglossia, delayed dental eruption, and lethargy. Tragically, the most severely affected puppies often do not survive the first few weeks of life without a diagnosis. Beyond congenital and primary acquired forms, we also recognize secondary hypothyroidism, which is rare and results from a deficiency in thyroid-stimulating hormone produced by the pituitary gland, or tertiary hypothyroidism, an even rarer condition caused by a deficiency of thyrotrophin-releasing hormone from the hypothalamus. Iatrogenic causes, meaning induced by medical intervention, also exist, such as surgical thyroid removal, radioactive iodine treatment, or the long-term administration of certain antithyroid drugs. Now, let us turn our attention to the question of prevalence and who is most at risk. Large retrospective studies have pegged the prevalence of canine hypothyroidism between 0.2% and 0.8%. The mean age for diagnosis is around 7 years, spanning a wide range from 6 months to 15 years. Certain demographic factors seem to influence risk. One United States study suggested that neutered dogs, both male and female, faced an increased risk compared to sexually intact animals. This is supported by retrospective data showing that neutering tends to be associated with a higher frequency of autoimmune conditions. However, a separate United Kingdom study did not find any association with breed, gender, or neuter status. The breed predispositions, however, are striking. Golden Retrievers, Doberman Pinschers, and mixed-breed dogs showed a significantly higher risk in the American study. Other research confirms the Golden Retriever is often the most frequently affected breed, followed by Griffons, German Shepherds, and Labrador Retrievers. Other breeds frequently noted to be at risk for inherited autoimmune thyroiditis include English Setters, Rhodesian Ridgebacks, Shetland Sheepdogs, and Boxers. In terms of age, hypothyroidism is most frequently reported in middle-aged dogs, roughly 5 to 10 years old. The clinical presentation of hypothyroidism is incredibly diverse because thyroid hormones are essential regulators of metabolic functions throughout the body. Because of the widespread effect of thyroid hormones, the clinical signs are generally similar regardless of the underlying cause of thyroid dysfunction. The classical signs fall primarily into two categories: decreased metabolic rate and dermatologic manifestations. In one study, nearly 70% of dogs exhibited both metabolic and dermatologic abnormalities. Signs related to a decreased metabolic rate are highly suggestive of the disease. Since thyroid hormones regulate oxygen consumption and the metabolic rate of most tissues, a deficiency leads to lethargy, mental dullness, weakness, cold intolerance, and an unwillingness to exercise. Weight gain or obesity is reported in about 44% to 47% of affected dogs. Interestingly, lethargy or weakness appears to vary significantly depending on the study population, reported in 20% of dogs in a United States study, but as high as 76% in a United Kingdom study, potentially reflecting differences in disease severity at the time of initial presentation. Moving to the skin, dermatologic abnormalities are reported in 60% to 80% of hypothyroid dogs. Thyroid hormones are vital for initiating the anagen, or growing, phase of the hair cycle. Consequently, hypothyroid dogs often experience alopecia, or hair loss, and failure of hair to regrow after clipping. The alopecia is typically bilaterally symmetric and first appears in areas of friction or wear, such as the tail, lateral trunk, and ventral thorax, while the head and extremities often remain spared. Owners might notice a rat tail appearance, where the hair on the dorsum of the tail is sparse. The remaining coat may look dull, brittle, or faded in color, sometimes resulting in a coarse texture or a fluffy, puppy-like coat due to the loss of undercoat. Beyond simple hair loss, other skin changes are common, including dry, scaly skin, seborrhea, which can be dry or oily, and conditions like hyperkeratosis, hyperpigmentation, and come-down formation. Hypothyroidism is also thought to predispose dogs to recurrent bacterial skin infections, referred to as pyoderma, which is reported in 10% to 23% of cases. Recurrent pyoderma, often unresponsive to conventional antibiotic therapy, may be the sign that finally prompts a veterinarian to check for underlying endocrine disease. If pruritus, or itchiness, occurs, it is usually due to these concurrent infections, such as pyoderma or malassezia. The most distinctive, though rare, dermatologic sign is myxedema, or cutaneous mucinosis. This involves a non-pitting thickening of the skin, most commonly seen around the cheeks, eyelids, and forehead. It is caused by the deposition of hyaluronic acid in the dermis, which occurs because the lack of thyroid hormone slows down the breakdown of glycosaminoglycans. This deposition can give the dog a classic, tragic face appearance. Fortunately, this specific change resolves completely once thyroid hormone supplementation is initiated. Now let us discuss the less common, yet sometimes life-threatening, systemic manifestations of hypothyroidism. Neurological abnormalities are strongly associated with hypothyroidism. One retrospective study found neurological signs in nearly 30% of hypothyroid dogs. These signs primarily affect the peripheral nervous system, although central nervous system dysfunction can also occur. The most well-documented manifestation is peripheral neuropathy, which often affects older, large, or giant breed dogs. Clinically, these dogs present with exercise intolerance, generalized weakness, ataxia, and sometimes partial to complete paralysis of all four limbs. Crucially, these dogs often lack the classic metabolic and dermatologic signs. The onset can range from a slow progression over several weeks to a more rapid presentation. Neurologic examination frequently reveals depression, weakness, proprioceptive deficits, and diminished segmental reflexes, especially in the pelvic limbs. The suspected cause of peripheral neuropathy relates to the role of thyroid hormones in cellular energy. Deficiency may lead to impaired sodium-potassium pump activity, slowing axonal transport, and leading to nerve dysfunction. The good news is that these neurological signs tend to resolve quickly, often within a few days of starting levothyroxine supplementation, with most dogs returning to normal neurological function within 1 to 2 months. Other specific neurological conditions linked to hypothyroidism include dysfunction of multiple cranial nerves, such as the facial, trigeminal, and vestibulocochlear nerves. Peripheral and central vestibular dysfunction have been reported, sometimes associated with abnormal brainstem auditory evoked responses. One study of 10 dogs with central vestibular dysfunction linked to hypothyroidism reported that the signs resolved entirely with thyroxine supplementation. Hypothyroidism has also been implicated in severe neuromuscular conditions. Myopathy, or muscle disease, has been rarely described. Additionally, unilateral lameness, characterized by forelimb lameness, pain in the shoulder joint, and atrophy of the supraspinatus muscle, has been reported and attributed to generalized neuromyopathy. All these manifestations improved or resolved with L-thyroxine supplementation, sometimes recurring if the treatment was withdrawn. We must also consider the gastrointestinal and swallowing complications. Megaesophagus, a condition where the esophagus is abnormally dilated, has been reported in association with hypothyroidism. Dogs with megaesophagus present with signs like chronic regurgitation of undigested food shortly after eating and productive coughing. Radiographic examination in affected dogs typically shows a dilated esophagus. However, unlike many other neurological signs, treatment of hypothyroidism does not consistently lead to the resolution of megaesophagus. One study found that while some dogs showed mild clinical improvement with hormone supplementation, the radiographic evidence of megaesophagus often persisted after 2 months of treatment. This inconsistency makes establishing a definitive causal relationship challenging. Similarly, laryngeal paralysis, which causes respiratory distress and stridor, has been reported alongside hypothyroidism. Affected dogs often exhibit generalized weakness and weight gain. While electrodiagnostic evidence sometimes points towards a more diffuse polyneuropathy in these dogs, establishing a causal link where L-thyroxine alone resolves the laryngeal paralysis remains difficult, as most cases are treated surgically. Moving to the cardiovascular system, thyroid deficiency affects myocardial contractility, heart rate, and systemic vascular resistance. Abnormalities include a weak apex beat, low QRS voltages on the electrocardiogram, and sinus bradycardia. Hypothyroidism rarely, by itself, causes significant myocardial failure. However, it can certainly exacerbate signs in dogs with pre-existing heart disease, such as dilated cardiomyopathy. There are documented cases, particularly in Great Danes, where dramatic, long-term improvement in cardiac function was seen after treatment for concurrent hypothyroidism and dilated cardiomyopathy. Hypothyroidism is also a known risk factor for atherosclerosis in dogs, a rare complication usually occurring secondary to severe hypercholesterolemia, which can, in turn, lead to impaired left ventricular function or atrial fibrillation. One study of severely affected dogs revealed first-grade diastolic dysfunction, characterized by impaired relaxation and abnormal heart filling, detected via echocardiography. In the reproductive realm, associations are often weak. In females, issues like prolonged periods between heats, silent heat, failure to cycle, spontaneous abortion, or low birth weight litters have been attributed to hypothyroidism. Female reproductive defects such as anestrum, failure to conceive, and galactorrhea, which is inappropriate milk production, have been reported. This inappropriate milk production may be linked to hyperprolactinemia, which occurs because the lack of negative feedback on the pituitary gland increases thyrotrophin-releasing hormone secretion, which in turn stimulates prolactin release. For males, problems like low libido and testicular atrophy have been reported, although a prospective study in beagles with experimentally induced hypothyroidism failed to show a decrease in libido or sperm quality over a 2-year period. Finally, we address the controversial subject of behavioral abnormalities. The most frequently observed behavioral signs are mental dullness and lethargy, which consistently resolve quickly upon thyroid hormone supplementation. However, the association with complex behavioral problems like aggression is less compelling. While aggression and cognitive dysfunction have been attributed to hypothyroidism, especially in rare cases involving myxedema coma or cerebral atherosclerosis, strong scientific evidence for a causal link in common behavioral problems is sparse. One prospective study using a standardized questionnaire confirmed a significant increase in activity in hypothyroid dogs after just 6 weeks of thyroxine supplementation. Critically, this same study found no significant change in any of the other evaluated behavioral signs, including aggression, after 6 months of supplementation. This challenges anecdotal reports and earlier studies suggesting thyroid hormone supplementation could treat aggression problems. The study also measured circulating concentrations of serotonin and prolactin, 2 neuroproteins potentially influenced by thyroid hormones and linked to aggression, and found that these levels remained unchanged during the 6-month treatment period. Beyond clinical signs, laboratory testing reveals predictable clinicopathologic findings in hypothyroid dogs. A mild, non-regenerative anemia occurs in 30% to 40% of cases. The most consistent finding is fasting hypercholesterolemia, present in about 75% of hypothyroid dogs, with hypertriglyceridemia reported in up to 88%. These lipid abnormalities are likely the source of rare complications like atherosclerosis and corneal lipidosis. Less common abnormalities include mild elevations in alkaline phosphatase and alanine aminotransferase. Hypothyroidism can also occur alongside other immune-mediated endocrine disorders, a situation referred to as polyendocrinopathies. The most notable associations are with hypoadrenocorticism and diabetes mellitus. In diabetic dogs with concurrent hypothyroidism, insulin resistance has been reported. The increased fructosamine concentrations often seen in hypothyroid dogs might make fructosamine an unreliable indicator of glycemic control in dogs with coexisting diabetes mellitus. Diagnosis of canine hypothyroidism, the challenge. Despite the clear set of clinical and clinico-pathologic findings, confirming a diagnosis of hypothyroidism can be remarkably challenging, leading to it being the most overdiagnosed endocrinopathy in dogs. The difficulty stems from the inherent limitations of the diagnostic assays and the large number of nonthyroidal factors that can artificially suppress thyroid hormone concentrations. Diagnostic tools include measuring total thyroxine, free thyroxine, total triiodothyronine, thyroid-stimulating hormone, autoantibodies, and performing stimulation tests like the thyroid-stimulating hormone stimulation test and the thyrotrophin-releasing hormone stimulation test. The total thyroxine and free thyroxine levels assess the output of the thyroid gland, while thyroid-stimulating hormone assesses the pituitary feedback loop. Total thyroxine, or TT4, is typically the primary screening test. It is highly sensitive, up to 100%, meaning that a normal result makes hypothyroidism unlikely. However, it is highly nonspecific, with a specificity of only 75%. A low total thyroxine alone should never be used to definitively diagnose hypothyroidism. Many factors interfere with this measurement, including breed, age, random fluctuations, concurrent illness, and various medications. The most notorious confounder is the nonthyroidal illness syndrome, also referred to as the euthyroid sick syndrome. This occurs when systemic illness, not directly related to the thyroid gland, suppresses the circulating levels of total thyroxine and free thyroxine. In one study of sick dogs, over 30% had total thyroxine concentrations below the reference interval. Importantly, recent longitudinal studies have provided crucial information on how rapidly these values normalize once the acute illness resolves. One study demonstrated that low total thyroxine concentration in acutely ill dogs recovers rapidly, occurring before discharge in 80% of cases, and normalizing in all cases within 2 to 4 weeks after discharge. Therefore, to avoid misdiagnosis, thyroid testing, especially total thyroxine measurement, should be postponed until 2 to 4 weeks after a dog is discharged from the hospital following an acute illness. Free thyroxine, or FT4, is considered a more accurate reflection of the hormone available to the tissues. It is measured primarily by equilibrium dialysis or modified equilibrium dialysis, which is considered the recommended method over other types of immunoassays. Free thyroxine is generally less affected by nonthyroidal illness than total thyroxine. If a veterinarian needs to assess thyroid status quickly in a sick dog, measuring free thyroxine by equilibrium dialysis is recommended because it is less likely to be affected by the acute illness, and was shown in one study to normalize within 2 days of admission in all dogs where it was initially low. The third key player is thyroid-stimulating hormone, or TSH. In hypothyroidism, the decreased thyroid hormone production should theoretically lead to an increased thyroid-stimulating hormone concentration due to the lack of negative feedback on the pituitary gland. However, the thyroid-stimulating hormone assay lacks sensitivity in dogs, and up to 1/3 of genuinely hypothyroid dogs may have thyroid-stimulating hormone concentrations that fall within the normal reference interval. The combination of a decreased total thyroxine and an elevated thyroid-stimulating hormone is specific for hypothyroidism. If total thyroxine is low but thyroid-stimulating hormone is normal, diagnosis is not excluded, and free thyroxine should be pursued next. If both total thyroxine and free thyroxine are decreased, hypothyroidism is usually confirmed. An additional layer of complexity is introduced by autoantibodies. Antithyroglobulin antibodies are found in 50% of hypothyroid dogs. Their presence supports a diagnosis of hypothyroidism, particularly lymphocytic thyroiditis, but is not diagnostic on its own. These antibodies can sometimes interfere with the total thyroxine assay, leading to an artificially high reading in some dogs who are actually hypothyroid. For dogs exhibiting clinical signs of hypothyroidism but having a normal total thyroxine, testing for autoantibodies is a useful next step. The complexity of diagnosis is further magnified by the number of common medications that significantly interfere with thyroid function testing. It is absolutely critical for clinicians to be aware of these drug interactions to prevent misdiagnosis and the unnecessary initiation of thyroid hormone replacement. Glucocorticoids, widely used anti-inflammatory or immunosuppressive drugs, can suppress total thyroxine, free thyroxine, and possibly thyroid-stimulating hormone in a dose-dependent manner. These drugs work primarily by suppressing thyrotrophin-releasing hormone secretion from the hypothalamus, leading to decreased thyroid-stimulating hormone. Immunosuppressive doses administered for 3 weeks can cause substantial decreases in total thyroxine, free thyroxine, and total triiodothyronine. Even topical administration of glucocorticoids to the skin or ears has been shown to decrease serum total thyroxine concentrations by 50% over a 3-week period. Phenobarbital, a common anticonvulsant, also profoundly affects thyroid function. It accelerates the clearance of thyroxine from the plasma by increasing its metabolism and subsequent excretion. Long-term administration, meaning over 1 month, can lead to decreased total thyroxine, with 15% to 75% of dogs having concentrations below the reference interval. Similarly, free thyroxine decreases, dropping below the reference interval in 35% to 66% of dogs in some studies. The thyroid-stimulating hormone concentration may be unchanged or mildly increased. The effects of phenobarbital on thyroid hormones are reversible, and it is recommended to wait at least 6 weeks after discontinuing the medication before performing thyroid function tests for accurate interpretation. Sulfonamides, especially potentiated sulfonamides like trimethoprim sulfamethoxazole, can cause true hypothyroidism and goiter. These drugs suppress thyroid hormone synthesis by inhibiting thyroid peroxidase. Depending on the dosage and duration, dogs receiving sulfonamides may exhibit thyroid function test results consistent with primary hypothyroidism, low total thyroxine, potentially low free thyroxine, and high thyroid-stimulating hormone. Because these effects can appear rapidly, within 1 to 2 weeks, thyroid testing should be avoided altogether while a dog is receiving potentiated sulfonamides. If hypothyroidism is clinically induced by sulfonamides, it is reversible upon cessation of the drug. Other drugs that influence thyroid tests include aspirin, a nonsteroidal anti-inflammatory drug, which has a substantial influence on total thyroxine levels by displacing it from plasma proteins. Clomipramine, tosyrenate phosphate, trilostane, amiodarone, and even inhalant anesthetics can also alter thyroid test results. Given all these confounding factors, nonthyroidal illness, drug interference, and breed-specific low reference ranges, it is easy to see why hypothyroidism is overdiagnosed. Testing dogs who lack compatible clinical signs significantly decreases the predictive value of a positive test result. Treatment and prognosis. Fortunately, once the diagnosis is definitively confirmed based on compatible clinical signs and corroborating laboratory findings, treatment is generally straightforward, effective, and relatively inexpensive. The standard treatment is oral hormone replacement using levothyroxine sodium. This synthetic form of thyroxine is given orally, typically at a starting dosage of 0.02 mg per kilogram, administered twice daily. Because levothyroxine absorption can be reduced when administered with food, it is ideally given on an empty stomach to maximize bioavailability. In obese patients, the dose calculation should be based on the estimated lean body weight. The response to treatment can be dramatic, particularly regarding metabolic and neurological signs. Clinical improvement typically begins within weeks. The increase in activity levels and resolution of mental dullness are often the earliest improvements observed by owners, sometimes within days to 6 weeks of starting supplementation. This improvement is generally seen before changes in circulating hormones are complete. However, resolution of dermatologic signs takes significantly longer, sometimes months, as the hair coat cycles need time to regenerate fully. Monitoring treatment involves tracking clinical improvement and periodically measuring total thyroxine levels. The goal is typically to achieve a total thyroxine concentration in the upper half or slightly above the laboratory's reference range, measured 4 to 6 hours after the morning pill. If thyroid-stimulating hormone was elevated at diagnosis, it is expected to return to the normal range, but confirming this normalization is not mandatory for monitoring unless there are complications. Once the dog is stable and symptoms are controlled, monitoring can often be scaled back to every 6 to 12 months. In specific complicating scenarios, treatment management needs careful consideration. If a dog is diagnosed with hypothyroidism and also has hypercholesterolemia leading to rare complications like atherosclerosis, the levothyroxine replacement, by correcting the hypothyroidism, typically resolves the underlying lipid abnormalities. For dogs presenting with gallbladder mucoceles, a condition associated with high risk of rupture and death in certain small breeds, hypothyroidism is a significant concurrent risk factor, increasing the risk of gallbladder rupture by over 4 times and the risk of non-survival to discharge by over 4 times, compared to dogs without endocrinopathies. For such patients, specialists recommend considering elective cholecystectomy early to lower the risk of severe complications, although some case reports suggest medical management, including levothyroxine, may resolve the mucocele. Furthermore, research exploring the cellular level effects of hypothyroidism has revealed that the deficiency of thyroid hormones is associated with elevated oxidative stress. Hypothyroid dogs show signs of this stress, including decreased activities of key antioxidants like superoxide dismutase and catalase, coupled with elevated concentrations of malondialdehyde, a marker of lipid peroxidation. This oxidative stress may play a role in associated pathologies like atherosclerosis. A promising finding is that treatment with levothyroxine sodium for 45 days significantly improved this redox imbalance, normalizing the antioxidant status in the dogs studied. In conclusion, canine hypothyroidism is a common and complex disease. While the clinical signs are varied and sometimes nonspecific, ranging from lethargy and obesity to severe neurological and dermatological issues, awareness of breed predisposition, careful exclusion of nonthyroidal illness syndrome, and vigilance against drug interference are essential for accurate diagnosis. With appropriate diagnostic confirmation and lifelong replacement therapy using levothyroxine sodium, the prognosis is excellent, allowing dogs to regain their vitality and quality of life. Thank you for listening. The titles for the reference papers are in the video description. From VetMed Digest, where we keep minds inspired, hearts light, and tails wagging,